morning to you all. My name is Yvo Roos. I'm a neurologist over here in Amsterdam, and I was asked to talk to you about epidemiology of stroke and intravenous thrombolysis. I thought it would be a wise idea to start with something like epidemiology, because when we talk about stroke, and there are many other terms used, for instance also hypoplexia, cerebrovascular accident, attack, and in Dutch it's called beroerte. When we use terms like that, it's important to realize that we're talking about, in fact, two diseases. One is the cerebral hemorrhage, or the ischemic stroke, and the other one is cerebral hemorrhage, which is also called hemorrhagic stroke. So it's important to keep that in mind. When you talk about a stroke, you're talking about two diseases, in fact. And to go even further, when you talk about a stroke, you can subdivide them in ischemic and into hemorrhagic bleeding, but you can also subdivide ischemic stroke in short-lasting, which is called a transient ischemic attack, or longer-lasting, which is a brain infarction, a cerebral infarction, but also white matter diseases. That's something completely different, but white matter diseases are important because they are consist of smaller infarcts into the white matter of the brain, but it can cause, for instance, dementia on later age. So it's a huge problem for society. And when talking about hemorrhagic stroke or bleedings, you can subdivide them into intracerebral hemorrhages or hemorrhages on the outside of the brain, which are called subarachnoid hemorrhage. So that's just to give you an impression. When we talk about stroke, we're talking about a lot of subdivisions. How huge is stroke a problem? When you look at it with a worldwide view, it's a huge problem. About 6.9 million ischemic strokes happen each year worldwide, and 3.4 million hemorrhagic strokes. Sometimes people die of a stroke, but in 2015 it was estimated that more than 40 million people were living with effects from stroke. So let's say dependency for everyday living. So that's a huge burden for society, also a huge costly burden for society. And in 2015, stroke was the second most frequent cause of death, just right after cardiovascular diseases in general. And it's also important, I already said that stroke causes paralysis and can cause aphasia, things like that, but it's also a cause of dementia. So when you look at it from a point of view of society burden, it's enormous. A little bit about the background of stroke, the risk factors. Age is an important risk factor. The older you are, the risk of stroke increases. High blood pressure, very important. Hypertension, high blood cholesterol, also very important. Diabetes, and heart disease in general. I already told you, when you talk about stroke, you can subdivide them into infarction and into hemorrhages. Brain infarctions and cerebral infarctions are far more frequent than hemorrhages, about 4 times as often. And how do we know whether it's a hemorrhagic stroke or it's an ischemic stroke? Well, there's the importance of the radiology department. On the left side, a CT scan, on the right side, an MRI scan. Using those techniques, we can see whether a patient has a hemorrhagic stroke or he or she has a ischemic stroke. And how do we do that? Well, I'm just going to show you a CT scan. Infarction versus bleeding. On the left side, you see a CT scan of a patient with a brain infarction or an ischemic stroke. And what you can see, can I use the pointer? Yeah, the pointer is working. What you can see over here is that there is a hyperintensity over here, which is the brain infarction. And on the right side, you see a hyperintensive dot, which is in fact a hemorrhagic stroke. So by using the CT scan or by using the MRI scan, we can see the difference between the two types. And that's important because when you look at it with a patient at a stroke from a clinical point of view, it's very difficult to subdivide them. You can't see from the outside of a patient whether he or she is suffering from an ischemic stroke or he or she is suffering from an hemorrhagic stroke. What we can do clinically is examine the patient, and we can look whether the patient has a paralysis on one side of the body. We can look whether the patient is aphasic, and we can score that. And we score that by using the so-called NIH stroke scale. And it's over here, and I know you can't read it, but that's not important because you're not all neurologists, so you shouldn't be doing my job. I should be doing that. But what you do on the NIH stroke scale is that you score things like level of consciousness. You ask questions to the patient where he or she is, and you score the answers. You give him commands, do this, do that, and you score whether he is responding to that. You look at how the patient is looking with his eyes. You look at visual fields, you look at facial paralysis, you look at the arm, at the paralysis of the arm, paralysis of the legs, and so on. You look at sensory things, language, and then at the end you give the patient the score. And the score can be minimal 0, and I hope that you all have a score of 0 because that's normal. And the maximum score is 42 on the NIH stroke scale score, but that's something we never see. That's theoretical. That's enormous. But to give you an impression, if a patient is suffering from a mild stroke, he or she has an NIH stroke scale score of, well, let's say 0, let's say 1, until let's say 10. If it's more severe, it's over 10 until 20, and at 20 it's really a severe stroke. Okay. That's what I wanted to tell you about the epidemiology, the terminology, something about the background. When you talk about ischemic stroke, you talk about a blood vessel which is blocked, which is supplying blood and oxygen to the brain. And when such a thing happens, it's important to realize that what we see at the patient is that he is immediately suffering from a paralysis. So let's say that there is a certain part of the brain which is provided of blood and so oxygen by a certain blood vessel. The moment this vessel gets blocked, seconds later or maximum a minute later, you will see neurologic deficits which specifically are part of the brain which is at that moment ischemic. But it's important to realize that there is a part of the brain which is ischemic and the part of the brain which is damaged in such a way that it's not salvageable. This is the brain from the underside. These are the blood vessels, and over here there is a blood vessel blocked. You see it over there. So what's important, what I just told you, that there is a part of the brain, let's say that's this part of the brain, which was normally dependent on this blood vessel for oxygen. So this part of the brain is at this moment, let's say it's 1 hour after stroke onset, it's not functioning. It's not functioning because there is too less of oxygen to function properly. But it's important to realize that 1 hour after stroke onset, there is a smaller part of the brain which is really damaged in such a way that the cells are already dead. So there is a difference between what we call the ischemic part of the brain, which is this whole part, and the dead tissue. This can't be salvaged. This part can be salvaged if you succeed in opening up the blood vessel. And this part is what we call the penumbra. So the part which can be salvaged is what we call the penumbra. Can we use that? It's not functioning, no. Okay, I'm just going to continue. I'm going over all the problems, and so I will survive at the end. Okay, I'm just going to show you how it looks on an MRI scan. This is already, well, I think 15 years old, a publication which showed what I just told you. And what you see over here are different modalities of an MRI scan. This is looking at the blood vessels. This is an MR angiography. This is
a technique which is looking at, well, what we think is the part of the brain which is at this moment, this is 2 hours after stroke onset, is already dead, can't be saved. This is the part of the brain, this dot over here, which is ischemic. And what you see is that it's larger than this part, and this is an MRI scan performed 5 days after stroke onset. And in this case, the blood vessel was blocked. You see the difference. It wasn't opened. And after 5 days, you see damage to the brain. This is an ischemic stroke, damage to the brain, which is almost the same as it was on this picture. Now, next slide, please. Does work? Ah. Oh, the pointer is working. Yeah, the pointer. Yeah, my hands are also working. This is another case. Over here, again, the vessel is blocked. Again, this is another patient. You see the brain infarction, the tissue which is dead. This is the part which is ischemic. But now something is done, and that's called intravenous thrombolysis. I'm going to talk in a couple of minutes about that. The vessel is opened, and what you see after 5 days is that there's not a brain infarction of this whole territory. No, you only see a brain infarction over here, which is more or less similar. You even see the small dots over here, more or less similar as it was in the acute phase. So what happened over here is that we opened up the blood vessel, and by opening up the blood vessel, we saved tissue which was ischemic, which was not functioning in the acute phase. So there was a paralysis, there were things wrong with the patient, but we succeeded in opening up the vessel. We succeeded in getting oxygen to the brain, and the cells were still alive, and they started working. So the patient improved. And you can imagine that there is a huge difference. A patient like this is living in a nursing hospital, living in a rehabilitation center, and he is, for his life, for the rest of his life, he's crippled. And a patient like this can go home and has minimal deficits. So there is a huge difference. Next slide, please. So how do we do that? We do that with intravenous thrombolysis. And what we do is dissolution of the thrombus. We do that by using RTPA, it's called alteplase, which is a product which dissolves thrombi. And it does that by tearing apart the threads of fibrin which are forming the thrombus. This is how it looks. It's 2 bottles. One with a powder, one with water, still water. You mix them together and you're going to give it to the patient. Next slide, please. So this is not something new. This was already thought of in the last century, the previous century. So in the 1990s, the first publications and larger cohort studies showed that you can give that to the patient, and sometimes you succeed in opening up the vessels, and there were some interesting results. And between 1995 and 1998, several trials were published showing clinical positive effects. We'll show them later on. And in 2000, a very important publication, in my opinion, was that it shows the relation between the start of the treatment, so the timing of the treatment after stroke onset, showing the huge effect. If you are early, you are much more capable of saving tissue than when you start later. Time is brain. And in 2008, we had a final publication of a large trial which showed that thrombolysis is safe and effective until 4.5 hours after stroke onset. Next slide, please. So, oh, I'm sorry, one back. So we conclude, yeah, go on. Yeah. So this is the timing. This is the timing, and this is showing minutes after stroke onset. Over here, 60 minutes after stroke onset. So keep in mind that stroke was already started over here. This is 60 minutes after stroke onset, and then continuing up to 3 hours over here. And this over here on the y-axis is showing the chance of a good recovery. And a good recovery means that the patient is going home and is able to care for him or herself. And what you see over here, you have to look at this line over here, is what you see that over time, the chances of a good recovery is going down. And when you talk about 3 hours after stroke onset, there's only a very minute effect of intravenous thrombolysis. And in fact, I already told you, we know that this line is a little bit higher, and it's, when it's striking 4.5 hours, there's no effect at all. But what you see is when you go back in time, the effect is much larger. Next slide, please. When you are starting treatment between 2 and 3 hours, you will need to treat at least 7 patients to get 1 patient with a good recovery extra. So Start within the 2 to 3 hour time window, and you will get one extra patient out of the nursing home into that he or she can go home. Next slide. When you start after 3 hours, you will need to treat 14 patients at least to get one extra patient into his nursing home. Next slide. But it gets interesting when you are between the time window between 1 and 2 hours. Then you will only need 3 patients to get one extra patient going home. And you can imagine if you are even quicker, within 1 hour, then the number needed to treat will be, well, 1 of 2. So, I was talking to you about going home, good recovery, and Charles asked me to specifically point out how we measure that, and we do that by looking at the modified Rankin scale score. That's how we normally score outcomes in research in stroke. And the modified Rankin scale score, a very simple scale, is a 6-point scale from 0 to 6. And when you score a 6, it's death. So that's very easy. And when you score a 0, you have no symptoms at all. And I hope you can read it, but when you look at it, you will see that gradually it talks about more deficit, more problems in doing things yourself. Next slide, please. I'm still clicking, but it's interesting. When you have such a thing in your hand, you start clicking. When you look at it, I was talking to you about patients with a good recovery. In most ischemic stroke trials, a good recovery we define as a 0 or 1. And you see 0, no symptoms at all, or a 1, no significant disability, which means that the patient is able to carry out all usual activities. And that's what we call a good recovery. And everything else, so 2 to 6, we call a poor recovery or worst outcome. Next slide, please. So, how was it in the 3 studies I already told you about the IV thrombolysis? Well, over here you see the 3 studies, the NIHSS, the ICAS-1 and ICAS-2 trial. Those were the 3 which showed effects of thrombolysis within 3 hours. And I mixed up the MRS scores, so I didn't subdivide them between 0 and 6, but I subdivided them in recovered, which is 0 to 1, dependent, which is 2 to 5, and over here you see 6, which is dead. And what you can see is that in each trial there is a larger proportion of patients which completely recovered by using IV TPA. You can also see that there are some differences in the number of patients who died. In ICAS-2 there was no difference. Over here it looked in ICAS-1 that there was some increase in patients who died with TPA, but that was logical. It had to do with the amount of TPA which was given in this study. And in the NIN trials there was a slight diminishment of patients who died. Next slide, please. So, this is how I would like to end. You've seen the epidemiology of stroke, you've seen terminology of stroke, you've seen what we can do in ischemic stroke to get recovery by intravenous thrombolysis. And you've seen that when we try to treat acutely patients, that we have to be as quickly as possible. So this is a poster which I found in America, which I thought is very good. Stroke is a brain attack, which is also using the 2 words stroke and attack in the same word. And it shows the things the people on the street have to know about a stroke: sudden loss of vision, sudden weakness, sudden loss of speech, and then the most important thing, if you know the warning signs, you can call your doctor, call 911, and I think that's a very important message. So that's something I would like to end with, and I thank you for your attention.